There's not a PERC positive. You can only use the PERC rule if it's negative. Now, you can use the different elements as far as our clinical decision making, because I'm not using pneumonia scores in a patient who has an infiltrate and a cough and a fever or whatever. I'm not talking about our patient here in this case here. But in that same way, there's a lot of really important elements with the PERC rule that you can ask about and use that in your clinical decision making. However, there's not a PERC positive. So just because one of these things is positive, the answer yes, does not require you to do a scan or to get a D-dimer on those patients. So this is an article that just came out a few months ago in Emergency Medicine Clinics of North America called Balancing the Legal Risk to the Clinician with the Medical Interest of the Patient. I only flash this up here in case folks want to take a look at it, because that balance that we think about is so important. And to me, it feels like PE is the poster child for a situation where we can cause patient harm by over-testing, but we need to balance out the risk of missing serious disease like PE. How do we reconcile that? To me, is by better data gathering with the history. Maybe sometimes the exam, lower extremities, etc., but oftentimes with the exam.
Absolutely. Great points to be made. Couple things I'll throw in as well. Just remember the increased risk of venothromboembolic disease after general surgery is multifactorial, but what really significantly elevates that is the use of general anesthesia. Understand it is a significant risk short term. So if someone says they had a recent surgery, that is a big deal. And it's not